Thank you all for joining us for this evening's event. I'm Anthony Carpi. I'm Dean of Research at John Jay College, and this is a seminar in our Racial Justice Community Recovery series. So today's event on integrating public health and emergency management is the latest in OAR's Racial Justice Research and Practice Dialogues. This is a series that has been going on since 2020 that's designed to bring together diverse scholars whose work exposes and seeks to remedy structural inequities across a variety of institutions. Last year, we covered health and mental health, economic inequality, discrimination in the criminal justice system, and the erasure of people of color from the historical narrative. This academic year, we're expanding our scope to highlight equity in post-disaster recovery, a topic that seemed particularly relevant given how the COVID-19 pandemic has thrown into sharp relief the many overlapping crises and structural issues that confront our society. So today, I'm really pleased to welcome three panelists who are scholars, activists, and practitioners in the venues of public health and emergency management. They will be discussing intersectional barriers to post-crisis recovery that were faced by marginalized and underprivileged communities and the ways that public health and emergency management overlap in promoting equitable outcomes. They will also talk about some of their own efforts to create community-based solutions that address unique circumstances and attempt to prepare for future challenges. Let me, first of all, thank several of our staff, Dan Stageman, Rachel Friedman, and others for helping to organize this event. And let me also thank our moderators, Dr. Jessica Gordon-Nemhard and Dr. Charles Jennings for their thoughtful leadership of today's session. Jessica is a professor of community justice and social economic development in our Department of Africana Studies. And Charles is a professor in our Department of Security, Fire, and Emergency Management, as well as the director of the Christian Reaganhard Center for Emergency Response Studies. Both are accomplished scholars themselves, and I look forward to hearing from them and all of our invited guests. With that, let me turn it over to Charles and Jessica.
Well, thank you, Anthony, and thank you ahead of time to our panelists. And we have a wonderful panel today. As you pointed out with the theme of the discussion, we're really centering it on the experience of New York City around the COVID pandemic. And so this is a perspective that's going to take into account kind of the broader public health system, as well as the emergency management and emergency response system, and then the community basis for understanding the impacts and responses to events such as COVID-19. And so I'll turn it over to Jessica.
Good afternoon, everybody. You're in store for a real treat. It's hard. We're going to talk about really hard questions, but we're also going to talk about, concrete responses and promising solutions, community responses, that kind of thing. So it won't leave you feeling depressed, even though the topic is obviously a hard topic to talk about. So first, we're going to have our panelists introduce themselves and give you a little bit of an opening statement, and then we have some questions for them. If you've got questions, please put them in the chat and we'll try to get to them. So I want to make sure that you get to know these people and get to know all the fabulous work they're doing. So first we'll have Dean Eiman ElMohandes, Dean of the CUNY Graduate School of Public Health and Public Policy, to give his opening statements, and then I'll introduce each panelist before they give their opening statement.
Thank you very much. Jessica, this is a big responsibility to introduce me first. I'm Eiman ElMohandes. I'm a physician and public health professional and academic. I am the Dean of the CUNY Graduate School of Public Health and Health Policy. Since the start of the pandemic and its impact on New York City in March of 2020, the School of Public Health and Health Policy has conducted approximately 20 polls, 20 surveys, including surveys to New York in general, to our neighborhood in Harlem, nationally and globally. Most of our work has been trying to understand better the impact of the pandemic on the health and health outcomes of various populations, but also implicating the economic stressors, the mental health challenges, the joblessness, the food insecurity, and the housing conditions of populations in New York, around the country, and around the world. Once the vaccine was available, we spent a great deal of time better trying to understand sources of hesitancy and vaccine equity across various groups and age groups in our city, nationally, and across the globe. I'm very, very fortunate to be with the other panelists today that bring a lot of perspectives that will be interesting to the discussion that we will conduct. Thank you.
Thank you so much. Next, I want to introduce one of our own, Associate Professor Jody Rory in the Department of Latin American and Latinx Studies at John Jay College, CUNY.
Thank you thank you, Professor. So my name is Jody Rory. I'm an associate professor. I am also the project investigator and founding director of the Rising Scholars of Justice program at John Jay College, and the president and CEO of a nonprofit called Hurricane Maria Assistance and Relief Institution Alliance. And basically what the nonprofit does is it aids victims of natural disaster and provides critical support to resources to minority and underrepresented populations. I work in conjunction with the American College of Surgeons, many of who are on our board of that nonprofit. And what I do is, in an effort to disrupt poverty and create the next generation of leaders in our most impacted sectors, I focus efforts to increase educational and developmental opportunities for a diverse population of aspiring doctors and lawyers, with an emphasis on promoting social justice and humanitarian aid relief brigades by working with local community-based organizations and governments. In 2018, with the support of our president and our provost, Carol Mason and Yi Lee, I was able to work to bring students from John Jay College to provide humanitarian aid and support to many communities throughout our Puerto Rico. During the pandemic, I have continued to work with John Jay students to really provide experiential learning opportunities, despite the limitations of the COVID pandemic, to work on gender-based violence issues, which are the forefront of my research, and which are populations that are have situations that are compounded by, for example, the COVID pandemic. So I work also with the large Caribbean diaspora in New York to provide support here. I also created the first free domestic volunteerism program in the US for the American College of Surgeons, Operation Back, with Dr. Germa Tefera and many, many other surgeons. And I have conducted extensive work during this project. But more importantly, as it relates to this, I have worked to provide support to earthquake victims during the pandemic that survived and that actually fled to New York City from Puerto Rico during the midst of this pandemic, working with our local government and community-based organizations to provide them with support relocation until conditions bettered. So I hope to be able to share some of that today. Thank you.
Thank you so much. And then we've got Assistant Professor George Contreras at New York Medical College at the Institute for Public Health. He's also an adjunct here at John Jay, and you'll hear he's got a bunch of credentials and responsibilities just like the other two.
Good afternoon. Thank you so much for the opportunity to be here. I'm truly humbled by being among the panelists here today. My background, I'm a true New Yorker, born and raised in Manhattan. 2022 marks my 30th year working on the front lines as a New York City paramedic. In addition to that, my experience simultaneously while working as a paramedic these 30 years, I've also been able to get into education, both on the pre-hospital care side, really relevant to CUNY. I created a CUNY-based paramedic program back in 2013, the last one that was actually created within the CUNY system. But then I have something else to add to the mix. I've worked in emergency management and also worked in public health, from starting at the New York City Department of Health and Mental Hygiene to working in both sexually transmitted infections, as well as the Bureau of Emergency Management, as it was called back in 2002, created really right after September 11th, and then went on to work in the private sector as Director of Emergency Management at NYU Langone. Really provided opportunity to be on the front line, work in administrative capacities, and then move on into education. In addition to that, now in my current role at New York Medical College, where I'm the Assistant Director of the Center for Disaster Medicine, our goal is to impart that knowledge to all health professions and other sectors so they can be better prepared for any type of event that could occur. Obviously, before the pandemic, we were focusing on other issues such as active shooters, which have been happening all over the world and all over the countries, particularly in the United States. And then we took a little pivot during 2020 to focus on other infectious disease and outbreaks and pandemics. In addition to that, I've been fortunate enough to go all over the world, focusing in Spain and Latin America and the Middle East, focusing on public health, EMS, and disaster preparedness. So I'm happy to be here today and impart a little bit of the experience that I've gone through and we've all gone through in these past 2 years with the pandemic. Thank you.
Thank you so much, Charles. Yeah, has the first question.
Okay, so the first question, which the group is going to address from their perspectives, is as follows. In spite of our collective experience with COVID-19, just explain for our audience how the system of public health works in terms of its institutional structure, including the voids often serviced by community-based organizations and civil society. And we'll go in the same order with the Dean first.
Yes, well, the public health system in the United States is very unique in the fact that many of the public health authorities lie within the state and are not federally regulated. There are exceptions to this rule where the federal government invests its resources through block grants in very specific areas where the federal government has the authority to delineate the characteristics of a specific program, such as Medicaid. But the vast majority of the public health response and infrastructure is state-specific. And that is not a small problem that manifested itself very clearly during the COVID pandemic, simply by some states having an extremely rudimentary and fractured public health infrastructure, and sometimes no equity of distribution of public health services across the state, where urban versus rural, or with a predilection towards serving certain segments of the community, be it racially or ethnically defined or otherwise. And that is a limitation that we have experienced very clearly during previous disasters, natural disasters, for example, in New Orleans and in Louisiana in general, during flood seasons and hurricanes and so on, where it became evident that the pre-existing public health infrastructure and the reserve systems are inadequate. And by the time the federal government is able to step in by manifesting either supplementation of emergency or relief funds, the population has suffered very significantly. And I do know that we have very clear visual images and memories of Katrina, for example, and how it affected certain segments of the population very inequitably compared to other segments.
Professor Rory?
Yes. So what I think what I'd like to add to what the Dean had just mentioned is, a global concern as well, right? That has been evolving, especially around issues of people that are very vulnerable and marginalized. So one of my area of expertise is gender-based violence. And we know that the gender-based violence cases have escalated during these times. And because of what the dean explained, the result is that people, predominantly women and children in abusive relationships have been forced to isolate together. So rights groups across the state, across the world have been sounding the horn over the potential blind spots in this area. And global experts have also stated that people affected by family violence are more prone to more violence when socially distancing. And so the importance of community-based organizations, I cannot emphasize enough, because a lot of the times this is where that gap can be filled when there is a disconnect between what the state is and the federal government are intending to do and what is actually happening in the ground. So we see similar patterns of these spikes across the United States. We saw them in New York City. We scramble, especially when you have executive orders that are not encompassing necessarily of the community-based focused people that are serving this particular population. We know that intimate partner violence increased 30 to 50%, for example, in 911 calls, right, in matters of weeks compared to previous weeks in the same week and period of time in the previous years. So I think that the inclusion of community-based organizations is essential in ensuring that communities, including gender-based violence victims and LGBTQ youth especially. I know that as a professor, I was really trying to provide as much support during the pandemic for LGBTQ youth who were forced to confine with family members that were not accepting of their identity or their choice or their lack of choice, right? To either be able to reside or not reside. And it rendered a lot of this particular community with much increased housing insecurity and hunger insecurity as well. So I saw an increase in particular with the communities that I serve of not only LGBTQ and gender-based violence victims, but also immigrant populations, right? Who have little resource or less access to legal resources, especially during the pandemic. And that was, I think, a void that we could talk maybe a little bit about how community-based organizations and organizations like our own institution, John Jay College, worked really collectively to fill.
Okay, thank you for that. And Professor Contreras.
Yes, so in order to just piggyback on what the dean and Jody just said, I think it was particularly interesting from the public health side to see how that rolled out in New York City. I'm going to focus on New York City because I had a unique perspective of being able to see it on the front lines, taking care of the people that were really sick. And then in the back of my mind, thinking from a public health perspective and emergency management perspective, realizing that there were so many gaps along the way, and it was very frustrating to see that. I mean, we are talking about trying to pull together a strategy where the World Health Organization was giving guidance. Here in the United States, we're looking for the CDC for guidance, and then it trickled down to the New York State Department of Health. And then in New York City, because of its large size and, we're talking about not many cities have their own health department. Of course, New York City having almost 9 million people, that we have our own health department. And then the coordination that needed to happen with that, with the New York City Emergency Management Department having their own health and medical division and their role that they had to play, in addition to getting other private stakeholders like the Greater New York Hospital Association, the Community Health Association of New York State, all trying to work together. And as Jody just mentioned, trying to work from these different perspectives of federal, state, and then in our case, city. We really look at milestones in the years that have just recently passed. For example, in 2020 was the beginning of the pandemic. We'll talk a little bit later about how the healthcare system was overwhelmed. In my 30 years, I really hadn't seen the New York City pre-hospital care system overwhelmed in the way that it was this time in 2020. Then we move on to 2021. The vaccines came. By the end of that, booster shots were being discussed. New York City pre-hospital care, again, being overwhelmed, not as much as in 2020, but still. And for the first time, I think we really were able to see pre-hospital care, the people that work on the ambulances, the EMTs and paramedics, playing such a pivotal role in public health in non-traditional capacities, where people were calling 911 and asking for advice, asking for vaccines, because they just didn't know that they couldn't do that. And now we are in 2022. We just got over Omicron. That we've had all these state and federal policies that have changed here in New York State. Obviously, the mask mandates have been lifted. New York City has followed suit with certain exceptions. But from a public health perspective, personally, in my opinion, we still have a way to go. I mean, we're still talking about, according to the CDC, if only 44% of people who are eligible for booster shots have gotten those booster shots. So we still have quite a way to go in order to get all of the partners in public health to work together to meet the goal of trying to protect the public of the United States.
Yeah, if I may add something to that, even in our great city, with the largest Department of Public Health in the nation, and thank you, George, for highlighting this, we still saw disparities that are inexcusable. Just as an example, we reside on 55 West 125th Street in the heart of Harlem. The mortality associated with COVID in Harlem was 500 per 100,000 of our population. The national average is about 300. So we cannot ignore these disparities. We cannot talk about them in an editorial fashion. They are here, they are around us. If you look, again, George mentioned boosters. When you look across our city, our great city, booster rates in Manhattan are 49. All you have to take is a subway up a few stops to the Bronx, where booster rates are 28. And the worst thing we can do during this crisis is blame the victim, because it's easy for us to perpetuate stereotypes. Oh, they don't believe in vaccines. Oh, they're afraid of consequences. Oh, look at their history. We did a study in Harlem when the vaccine was introduced to people above the age of 65. There were no difference in the vaccination rates if you are Black, Latino, white, or Asian. You know where we found a difference in vaccine rates? It was geographically within Harlem itself. So certain zip codes that had no access to clinics had low vaccination rates, and other zip codes that had better access to clinics had better zip codes. Racial differences didn't make any difference. When it was 65 and above, people knew the vaccine was good for them and was a lifesaver. So the most dangerous thing we can avoid is perpetuating stereotypes and myths.
Thank you,
Absolutely.
Yeah, go ahead, Jody.
No, I just want to add, access, right, to primary care and quality, equitable primary care is a huge issue in New York City, and it is a huge issue across racial groups and socioeconomic groups across the United States. I'm going to defer to the dean on the data, and there's no need to reiterate it. But I also want to say access to any type of remedies, including mental health, which we all know is essential in trying to overcome the pandemic, right? Education about the vaccine, right? Accessibility to equitable healthcare and access to mental health. We see this firsthand at professors at CUNY, right? And we work, and I'd love to be able to talk about that maybe in the next question. But access to mental health, because you see these rates of morbidity, of death, right? But you also have secondary consequences. What about these children that are left without parents, right? What are we doing in terms of the college students that are left now as head of households? What if any of those parents are undocumented and they don't have access because of fear of immigration? There's so many other socio and psychological barriers that also compound and need to be discussed that are not equitable, and they're clearly based on these racial and socioeconomic lines.
Thank you so much. You guys already sort of bled into our second question, but I'll repeat it and then start with Professor Contreras. and then see if the other two still want to jump in if we didn't finish their contributions. But we wanted to talk more about, let's get into more details about the disparities in public health and health outcomes and how they, as you already said, contributed to different COVID outcomes. How, the communities that our faculty serve and that are served by New York City's diasporic communities, right? How are those who are already suffering national disasters doing during the pandemic? What are the compounding impacts with national disasters? I think, Professor Contreras, we thought you could talk about some of your EMS experience, but obviously talk about anything you want. Then we can move back to Professor Rory and then with the Dean.
Thank you very much. Don't tell me to talk about anything I want, because I'll talk about pink flowers out there. But I wanted to really bring it back and offer this opportunity to have people who are attending understand a little bit better how New York City EMS works. And as I said, 30 years doing this year, I'm thankful that I'm still able to do it. New York City is probably one of the largest pre-hospital care systems in the world by volume. They average about 1.7 million calls every year, which comes out to about 4,600 calls a day. And I put that number out there because what happened in March of 2020 is unprecedented. And pre-hospital care here in New York City, people see the ambulances and may not necessarily know who's the staff who's working on the ambulances. We have emergency medical technicians who provide basic life support and paramedics who provide more advanced care. But on March of 2020, remember that 4,600 calls that I mentioned earlier. On March 30th of 2020, we surpassed 7,200 calls. So what did that do? That led to a trigger in order for New York City to ask for assistance from the federal government to say our system is just overwhelmed. And they activated what's called about it in the news and the media, maybe when they first started or when they ended. But what that did, it allowed New York City to ask for help in terms of personnel and ambulances to come from all over the country. These were predefined, pre-approved contracts that were already in place. And they sent, in March of 2020, they sent 400 ambulances with about 1,600 EMTs and paramedics to New York City to provide assistance in handling the unsurmountable number of calls that were coming in through 911. And they also facilitated interfacility transfers from the hospitals when there were all those different sites in like the Javitzes and the convention centers and the Comfort Ship, all those different additional surge capacity sites that were opened up. And they came to assist us. And so they were a huge help. Quite interesting to see ambulances from all over the country driving around New York City, but it was very, very much needed. In December of 2021, a lot of people don't know, those numbers in the 911 system were creeping up again. The call due to Omicron, people were starting to call 911 a lot. And I don't know about you, but I rarely have ever heard the mayor and the fire commissioner of New York City making public service announcements back in March of 2020, asking people to not call 911 unless it was a true medical emergency. Because that's what people were doing. People were calling and it wasn't necessarily for an emergency reason. People were calling because they wanted to get tested. People were calling thinking that they can get vaccines from the ambulances, from the personnel, without lack of information and the awareness that is not out there. A lot of people don't know during those times in March of 2020, the system was so overwhelmed. There were disaster protocols that were put in place. And far be it for me to talk about those times, if someone, one of those protocols was, if we get called to somebody's house and they were not that severely sick, they were advised to stay at home because the hospitals were overwhelmed. Another huge, really out of the norm policy that was out there is during the first wave, resuscitation efforts, the disaster protocols were 20 minutes of resuscitation time. If there was no successful outcome, person was pronounced dead on the scene. So talk about mental health consequences, both from the patients, families, loved ones that were there, and those providers who really were desperately trying to save people's lives, but obviously the outcomes were not positive, and we had to tell their family members that the person died, and then tell them that we're not taking the deceased anywhere and we're leaving them there at home. Because we know what happened with the surge in burials and the delays in funeral directors being able to process the deaths. So, you know, mental health, huge thing, not just for the communities, but I'm a big advocate that we also have to play and keep in mind the mental health of all the people that were out there, both from the hospital personnel to those that were on the front lines, on the ambulances. It took a huge emotional toll on everybody that did that. On 12-hour shifts, I had to deal with taking care of people who I thought I would be able to help and not able to help. And I have to tell the family members, you know, that that's all we can do for them. And they were not going to the hospital, trying to explain that to them, you know, trying to explain what are all those trucks that are parked outside of hospitals, those refrigerated trucks, because hospitals are not made to have large number of morgue space in their facilities. And so each one of those refrigerated trucks held up to 52 people who had died at that facility. And once word got out of that, then people started to get more involved of what was going on. And, you know, for me, working as a paramedic, I did see that I was going to different communities and seeing that there was a definite lack of awareness, health literacy, less access to healthcare. They were just calling 911 because that was the only way they could get into the healthcare system. It's still going on, 21st century. People still have difficulty getting good access into the healthcare system. That's all I have to say.
Thank you so much.
So-
So, yeah, go ahead.
Yeah, so I can pick up on what George was mentioning. I mean, just frontline, we had students calling us exactly with that situation, right, George? My mother is deceased. There's small children in the house. There's no other parent. We're sleeping in the car until somebody can pick up the body, and it would take 2 days. How do we arrange for funerals or we're, you know, trying our best to work within our communities, because as the dean mentioned, we know that they're, you know, Harlem, the Bronx, these are the poor communities that are really taking a hit, and there's nowhere to be able to bury the deceased, and the option was cremation, and how that then conflicted with people's personal religious beliefs on what should happen to your body once you're deceased. The financial burdens were astronomical. To compound this situation, we have a large everything diaspora in New York City. I particularly work with the Caribbean diaspora, specifically Puerto Rico, and they were going through earthquakes in the middle of this pandemic. And so to start receiving 17 people in my home and try to figure out how do I make this safe, and trying to talk to our board members who are physicians and surgeons, and try to talk to people at John Jay to try to get resources for these displaced people. Really, these affected migratory patterns exacerbated an already strained financial system, using the 330 clinics, which I'm sure the dean, you know, could talk a little bit about, because they collect a lot of data, federally funded health clinics, to help us with people who left their homes or were displaced with no ID, no social security, no health insurance cards, no way to be able to prove that they are who they say they are. Working with our elected officials to try to get them the proper paperwork so they can access healthcare in the midst of the pandemic and enroll their children in school within safe guidelines. All of those factors affected us. Let's talk about something positive though, because we want to include some positivity here. One of the things that we were able to do through the nonprofit and John Jay College is work with our students, because before COVID, a bigger pandemic that has been ongoing has been this gender-based violence issue. Whether we want to recognize it as a pandemic, a global pandemic or not, I would argue that it is. So we've been working with students at John Jay to help document gender-based violence through national organizations, Women Count USA, Seguimiento de Casos in Puerto Rico, to support the promotion of these victims that find themselves, because of this confinement and this lack of access to resources and healthcare, primary care, and law enforcement officials, right, authorities that can actually are the first line for these victims, to try to get them support, to try to nexus them with areas where they can be safer within the guidelines or the circumstances of the pandemic. Researching these cases of women that the aggressors have taken advantage of this pandemic, right, to disappear or die, right, or that really have been murdered, but other things are blamed because of the lack of law enforcement, due to the curfews and the confinement and the lack of staffing in these agencies. And this happened in New York City, and it happened across the world. And it's something that we don't talk about because we just think, not that the pandemic is just a thing, but we don't think of things holistically in our communities. We don't think of them as happening with existing issues that are also public health issues.
Yeah, I think we can drown in our tears recounting the past, but I think we have to be mindful of the future as well. In our most recent poll in New York, we discovered certain discrepancies that are fairly serious. One of the issues that we discovered was that, first of all, as George said, clinical depression is still quite high. At the very onset of the pandemic, 1 in 3 New Yorkers were depressed. By 1 year into the pandemic, it was about 25%, and now it is 18%. So 1 in 5 New Yorkers remains to be depressed. These rates are higher in certain groups. We look at especially the Latino group, the rates of depression are higher, and they are higher for a variety of reasons, one of which is economic. We looked at food insecurity across various racial groups, and one thing that's very concerning is that in our most recent poll in New York, 35% of the respondents said that they were suffering from some form of food insecurity. They were not sure that they had enough money to buy food to put on the tables of their families by the end of this month. Okay, this is not a tearjerker. This is a very practical thing, because a year ago, it was 29%, meaning that food insecurity in New York has increased, not decreased. And that's because there are many programs, federal and otherwise, to support food insecurity that are now beginning to be rolled back, and funding that is beginning to be rolled back. And therefore, people are suffering more, not less. And when you look at racial and ethnic disparities, you are surprised to see that amongst Latino populations, food insecurity is 45%. 45%. So you are talking about families where almost half of them are suffering from food insecurity. We have to look forwards. We have to eliminate some of the disparities that I talked about in vaccination and boosters. Furthermore, we need to understand that many communities have suffered from a setback in their normal immunizations and their normal healthcare. It's not just about the deluge that George Contreras was talking about. It is about their regular healthcare, their diabetes, early diagnosis of cancer, managing their bronchial asthma. All of these things have had to take second place to the urgency of the pandemic healthcare delivery. So, catching up on their healthcare. B, catching up on things that they may not have had in the past, even like dental care. Making sure we understand that their mental health continues to suffer significantly, especially in certain communities and in certain racial and ethnic groups. 4, making sure that they are now boosted, because there is no telling that we will not suffer from another wave of this COVID pandemic, and they have to be better prepared. Otherwise, we're going to retell George's story again and again and again. Finally, we cannot talk about the outcomes of people that were exposed to the COVID pandemic without talking about joblessness, without talking about housing, without talking about their economic stability. And in our most recent poll, again, 34% of our respondents said that they are worse off economically today than they were at the time of the onset of the pandemic. 34%, 1 in 3. But people are optimistic and they say, but in 1 year, only 17% of them said in 1 year we'll be worse off than we were when the pandemic started. So New Yorkers by nature are optimistic. By nature, they're resilient. And if you ask them tomorrow is going to be better or today, many of them will say tomorrow. So we have to take advantage of this optimism. We have to take advantage of this go-getter attitude, but we have to supplement that with resources. A very good example, and that's going to be my last statement here about listening. Very early on, when the vaccine was available, we asked people in Harlem and people in the city where they would like to get the vaccine. And African Americans were very clear. They said, we would like to get the vaccine at our doctor's office. And when asked why, many of them said, this is a new vaccine. We don't know what's up with this thing. We trust our doctor. We want our doctor to give us the vaccine. At that time, no primary care clinic, nor any physician clinic was administering the vaccine because, as you know, it required very cold storage that the clinics were not equipped to provide, minus 70 degrees, a very cold storage. As a result, people shied away. And then we were surprised. When we asked the Latino population, where would you like to get the vaccine? They said, I would like to go to my local pharmacy. So there are even cultural differences amongst groups. And in order for us to require of them to fulfill their part, we have to listen to them and try to fulfill ours as well. These are lessons that we have learned and hopefully will be applicable to the future.
Thank you so much. You guys have done a great job. You actually already answered a lot of the question I was going to ask next about intersectional challenges, race, gender, et cetera, and, compounding impacts. So I really actually want to get to, we have one question in the Q&A. Let me get to that because that moves us closer to the conversation we wanted to have about where do we go from here, right? So the question is, the COVID-19 pandemic has impacted marginalized communities far more than the more general population in the United States. We've heard a lot of that already from all of you. Moving forward, what are some lessons we can learn from this event to ensure that the next pandemic does not hurt as much as this one? What special factors do we need to keep in mind for marginal communities? I guess I should tell you what order you should answer them in. How about Professor Rory first, then Dean ElMohandes, and then Professor Contreras?
Okay, great. So thank you for that question. I think it's imperative. So I really firmly believe, and again, I'm going to talk about the area of expertise that I try my best to fill. I believe in working with community-based organizations. They are the filler for all of the problems that the Dean set out from the beginning. Non-governmental organizations and women leaders who participate in this discourse and this service have to be included in the decision-making process of the states and the nation's emergency response plan at every level of government. Inclusion of their concerns in these executive orders is beneficial to all of us. It will fill many of these voids. And in cases where non-governmental organizations are providing the primary service for survivors, right, or trying to administer this. So Dean, one of the other issues that was raised is churches, right? In the Black community, churches are essential. And so if we know that people look to their religious leaders, right, whatever that religion is, and even persons that are not within, are atheists who don't have a preference, right, might be more trusting of something in our community. We have to equip them with the capacity to also be participants in this process, because as we know, there's a lot of miseducation nationally about vaccination. But these people, they need to have a seat at the emergency management table. They have to have a voice in the policy decision-making process as it pertains to vulnerable groups. Those groups that are making decisions have to reflect the populations that are disparately impacted by the outcomes that the dean delineated in the beginning. So it's essential, especially during a confinement, that the executive orders be written clearly, that they include why persons are being isolated, how they should proceed with the isolation, and what information is necessary and how that information can reach those populations. Because it's a miss if you don't have internet in your home, which I can tell you as a John Jay professor, a lot of our students didn't have internet, right, capacity during the pandemic. And a lot of our students were out of education because of that, right? And so we were struggling, maybe sometimes out of pocket, buying them hotspots so they can just partake and be quote unquote normal within this total disorder. So I believe that this intersectionality of race, ethnicity, socioeconomic class, status, sexual orientation, gender, language, immigration, age, all of these factors have to be added to the equation. And women and members of these communities, LGBTQ immigrants, they're rendered to less class status when this is absent. So these are essential to produce equity in citizenship, equity in access. And we know inherently, from these federally funded health centers, that they were created because of, in part, this disparity, right? And this is also the problem in the diasporic communities that are represented when people are migrating back and forth, right, to be with family members, because as we know, especially I could tell you from the Caribbean, we have already a crippling healthcare system. So that financial burden is going to be exacerbated. Until we address that, we're going to continue to have this problem.
Thank you. Dean ElMohandes.
I think this is a moment for us to study the terminology of equity versus equality. And equality means, I see all of us on the panel today. I see Jody, I see Jessica, I see Eiman, I see George, and I see Charles. And equality means every one of us is going to get a sandwich. Equity means Charles has been famished. He is starving. I'll take half a sandwich, but save him. What do I mean by that? I mean that this is an opportunity for us in New York, one of the greatest cities in the world, with one of the strongest public health infrastructures and economic platforms in the globe, should look very carefully about distributing resources not equally but equitably, looking at the weakest link in our chain. And as they say, the chain is as strong as its weakest link. And therefore, there are deficiencies and deficits that have become obvious. Listen to George's stories, where there needs to be an effort to serve the most underserved and enrich parts of our service platform that are the weakest and the easiest to crumble. Furthermore, we need to understand that public health is an integrative concept, is a multidisciplinary concept. You cannot think only about healthcare delivery or even prevention alone. This pandemic has shown us in very concrete ways that public health is about housing, it's about transportation, it's about income, it's about autonomy, and it's about absolutely availability of work opportunities. One of the things that we saw early on was there was such a focus on vaccinating healthcare workers, but we didn't think of other frontline workers that were in restaurants or hotels or building sites, and they were exposed so significantly that many of them got sick and died. And they were not prioritized in our vaccination campaigns. And as you imagine in the service industry, these people didn't have cars, they used public transportation, and they were exposed and they got sick. And we don't want to make these same mistakes again. These are probably manifestations of us not being sensitive. And it took a moment before vaccinating these groups became a priority as well. So there are a lot of lessons to be learned, and maybe it is time for us to administer equity for a change.
I'd like to piggyback on what the dean has just mentioned and what Jody has also mentioned, in that one of the things that I think we can provide as solutions, and this is just my humble opinion as someone who's been taking care of people who have died in my arms, is that we need to do the best that we can to raise that level of awareness, raise that health literacy in all communities, and include mental health awareness and preparedness for everyone, not just in New York City, but anywhere we can. As the dean just mentioned, one of the things that I often said is this pandemic has removed that blanket that many have chosen to see or not see, and thought that, whether it came about vaccines or the pandemic, that this was going to affect people in different ways. It did affect people in different ways, and a lot of it had to do with whether they had access to healthcare, whether they were well informed, and it didn't matter if where they were working, in terms of they were going to be exposed. As he just mentioned, from the very beginning, when vaccines were available, I was shuddering to think, well, we have a lot of what they classified as essential workers who were not eligible to get the vaccines. And now you're mandating people to go to work, whether it was gas stations, restaurant workers, grocery store workers, employees, and meanwhile, they were not eligible to get the vaccines in that first wave. Well, if you put them out there and telling them they have to go to work because they're essential, they should have been included in that first wave because they were still out there. As I've said before, people that were in that category of essential and healthcare workers, whether it was nurses, physicians, respiratory worker, whoever was in the hospital, we never took a day off. We don't know what it meant to be locked down because we never experienced the lockdown. We continued to go and work and provide whatever service we provided to the communities. So I think we need to do a better job, whether it's in the public sector, private sector, but I also think academia needs to get more involved and do more. There are programs all over New York City and New York State that have created programs. I salute John Jay and CUNY that have created a lot of different programs that have focused on different aspects of the pandemic. John Jay created a public health emergency management course. But I really, as Jody mentioned earlier, we need to get the community members involved in assessments. It's just 101 when you're doing health promotion and prevention. Get to know your communities, get to have buy-in from the communities, get those leaders from the communities involved, because we as outsiders do not know those communities as well as the people who live in them. And so they know the intricacies of their neighborhoods. And one final note is to promote personal preparedness among everyone. We all can do a little bit to learn how we can take care of ourselves until we need additional assistance. And I think if we all work together, I think we have a great opportunity to make a stronger and healthier New York as a whole. Thank you.
Yeah, thank you so much. In my research on mutual aid and cooperatives, you also see the same thing that you all are talking about in terms of ways that people already used to coming together and helping each other, just double it up during crises and jump in, figure out how to pool even more resources to do more. And so I think also recognizing the ways that we already help and support each other, and then making sure our systems, right, allow us to do that, I think is also another way that we can think about this. We're getting close to wrapping up. There's another question in the Q&A, And Charles was going to lead us in a wrap up. Jody, I think you want to say something?
Yeah. So
Go
I
ahead.
think Dara had posed a question. I just want to give some examples, right, of ways that we have been responsive at John Jay. I mean, I think I could talk about my personal experience. As a result of the pandemic, I have worked with CUNY Central to have social work interns, right, candidates that are for social work as part of my curriculum, right? Because I understand that the pandemic has exacerbated the mental health status of maybe some pre-existing conditions our students may have. And as the dean mentioned earlier, the increase of our population, especially as a Hispanic and minority serving institution. And so the Black and Latino communities are suffering these mental health rates at exorbitant rates in comparison to other populations. So I know that we've been doing that. Okay, I'm seeing Dara's comment. And how can we provide help outside the college? I led mental health brigades to diaspora countries, Puerto Rico and the Caribbean, right? So we brought the lack of healthcare providers that they had, whether they're primary care physicians or psychologists or psychiatrists, and leading these brigades with local community-based organizations within our community in New York City, right? And within the diasporic places that we're able to access. And we've been doing that within our department. Dean, I think Jessica.
Can you guys hear me? I'm having some technical issues.
Yeah.
Charles?
Yes.
I don't know if Charles wants to take
So
over moderating. Yeah, go ahead, Professor.
Go ahead and finish. Yeah. Jody, were you finished?
Yeah. I mean,
Okay.
so I think that we can do more, absolutely. And I know that we have the qualified people to be able to do it. I think they just need. We're a big institution. I think we could do more within ourselves to organize ourselves better. And we could use the support from the administration and the leaders at the college to be able to do that. I know that faculty are more than willing to take on that charge, but they just need the opportunity and space. And I think that we can collectively organize to be able to get that done, especially having learned what we did during this pandemic.
Okay, I've got a number of questions, but I want to throw out to the audience. Again, this is the last chance, so if you have a question, please send it now. And before we go around for kind of closing statements, I just wanted to point out, I don't know if people had seen and talking about kind of the material conditions that underlie public health is the unemployment rates.
Sorry, Charles, but the dean has to go. So do you want to?
Oh, he's got to go.
Yeah, let him have his last word and then you can continue.
Oh, sure. Go ahead, Dean.
I think the pandemic has been a wake-up call. The last thing I would like to see is a return to where we were before that. And our call for social justice and equity has been fired by examples that we saw. And there is nothing more precious than human life that has been lost unnecessarily. I think it is time for us to understand that we as a society need to bring all disciplines together, being education, being economic, being public service, being policy, and being politics, as well as the healthcare, to work together towards a new chapter in our preparedness. The city has funded a pandemic response institute. We at the CUNY School of Public Health are partners with Columbia University in this new endeavor, and we hope that we will be able to contribute in some way in the preparedness for the next chapter of the next challenge. With that, I thank you so much for inviting me, and I'm looking forward to hopefully many more conversations around this topic. Thank you very much.
Thank you so much.
Yes, thank you, Dean. So I think keying off of the Dean's comments, and I know our time is getting short, but I wanted to interject this, is the unemployment rates in March of the unemployment rates right now are higher in New York than they are in other regions of the state, which is the exact opposite of how it normally is. And so I'm just wondering, as COVID continues, what are the implications of that for kind of the ongoing challenges to maintaining public health and being able to approach something like recovery for those at-risk communities. And either of you can jump on that.
George, I'm going to defer to you first.
Sure. I mean, one of the comments that you just made, Charles, about unemployment, I think, you know, it just goes back to what I saw in the front lines. I mean, I was going to people's apartments and we were talking about seeing 3 or 4 generations of families living in one apartment and the impact of one person being sick, what kind of impact it had on the entire household. And compounded by that, when the the Department of Education closed schools in the beginning, we had all the children in the homes, supposedly remote learning, right? When 1/3 of the students didn't have access to internet or laptops, as Jody mentioned, just talking about that. And then we had older, you know, 3rd and 4th generations in there. I mean, I just saw the fact of how one person can really take apart the entire household. And when it comes to unemployment, what we saw in the beginning, the first wave, really was a very powerful thing to see. And I don't, you know, when you see it on the news, it's one thing. When you see the stats is another, but being able to match up of a name and a face with those numbers, it's really powerful to see that. And I think it just increased my ability to appreciate what the level of impact of the pandemic really had, because I was able to see many of those faces behind those numbers, you know. And in New York City, obviously we were an epicenter in the beginning and we continue to struggle from then forward. I think it just allows us an opportunity to see how much more work we have left to do in order to improve and protect everybody's public health.
And, you know, if I could tag on, Charles, to what George is saying, and financial consideration, see, they are evaluating and responding to financial costs borne by these households, and they're working to compensate individuals for income losses associated with the quarantine. But the packages have to be considerate of the reality that in households, for example, where gender-based violence exists, or it may exist, women are often disadvantaged by economic stimulus packages that are paid to the aggressor when the taxes are filed jointly. Right? So individuals should have the option to choose subsidies to be paid separately to each person in the household. This is especially true of LGBTQ plus youth, many of whom we serve at John Jay College in CUNY, as opposed to family units. And this, I think, can assist in mitigating, you know, the gender-based violence survivors' economic dependency on their partner. The same goes with intersectionality of race, or the issue of homelessness or insecurity, right? How do you reach these most marginalized populations, immigrants, right? How do you reach them during this financial crisis that they're facing that has rendered them, you know, with such grave rates of homelessness, housing insecurity, and food insecurity? And again, I can't emphasize enough, community-based organizations are key and essential in this. Women leaders, non-governmental organizations that provide services to these particular vulnerable populations, organized religion, and other organizations that really supplement this gap that the dean began this with, of the disconnect, right, between the intention, the well-intended as the government may be, but the inability to connect to these communities and provide equitable assistance.
Yeah, absolutely. And I think you've hit on a theme that with the new FEMA administrator has talked about equity as a real thrust of kind of FEMA reform. And we'll see how far that gets. But in the last couple of minutes here, we wanted to give you an opportunity for last thoughts. And so we'll go with Professor Contreras first.
Thank you, Charles. You know, again, I think that if we learned one thing, we can pull anything out from this experience in these past going on more than 2 years. I think it's that we need to push ourselves to do better, both as practitioners, as academics, as activists, as leaders out there in the fields of public health, in the fields of emergency management. And I think that we need to do the best that we can to offer that opportunity to everyone, right? We're talking about racial inequities. We're talking about equalities. We need to do the best that we can to offer that opportunity to everybody, because, you know, from seeing people on the front line and seeing the questions that were asking me, one of the things that concerned me was the fact that people were asking me questions or asking for services. And I said, well, you know, that's not how it works. This is how it works. They just didn't know. And if they don't know where to get the help, the assistance, or even know where to, you know, just refer them to the resources, make it more available, make it more, whether it's, you know, we can't really rely on technology as much because, like Jody said, what if they don't have access to the internet? What if they don't have access to laptops? You know, one of the most frustrating things that I saw is when the vaccines came out and, you know, all the sites were, all the announcements were saying, well, just go online and schedule, make an appointment. Well, there's a lot of people who couldn't go online making appointments. And we heard these wonderful stories of high school kids helping their seniors make appointments because it would take 2 hours, 3 hours to make an appointment. So, I mean, it's just amazing the disparities that we had in places that we didn't even expect them, because we're kind of tunnel vision into one thing. So I think we really want, you know, again, and that's the importance of getting the input from the community, getting the input from the people that are living in those communities to see how can we best reach and get that information out. You know, we have to remember, keep the public in public health, make sure that we keep them involved in what we're trying to do and trying to do for them. Thank you.
Yeah, I see our president made a comment, and yes, President Mason, we did respond, but I want to pose this. I think that during that particular period of time, it's the burden fell on the individual colleges to be able to do that, and I think that, you know, that we have learned a lesson on how to have a more efficient way, right, from a bigger sense of government to provide all students with access to internet as soon as possible, or any type of electronic commitment. And I know we've partaken, you know, we've invested much in technology. Yes, and I know that we also brought Chromebooks. But in the beginning, it was very difficult to really address this problem. And my point was, I think the faculty did the best that they could, right? To try to help and support and fill that gap until we were able to catch up. And I know the administrators did that as well. So I just want to clarify that point, Charles, that I wasn't saying we weren't responsive. I'm saying just across the state, this was a really big issue, yes. Right? And I think that we addressed it the best that we could at our college. But it's very clear to me that this was not the case with every institution, right? Because we service, we participate in national programs. And so we service students from all across the United States indirectly through our programs and nexus with them. So, you know, I think that, you know, civil society has to be prepared to understand how to best assist the populations that we're talking about. And they also have to understand how to practice acts of solidarity in everyday interactions that can assist all of us. And it's especially important to be aware of and center the most vulnerable members of our community when we're thinking about responses. And again, partnering with community-based organizations that understand these populations best, including within our systems of academia, people that really understand these people best, and also making sure, you know, that we have enough mental health support now, especially, right? Because we're still not fully at the end of this, as the dean clearly said, and the consequences of mental health support have been just immeasurable and so long lasting. And I think we are still dealing with this. I know, at least as a faculty member, those of us that, you know, that are on the call, we're still dealing with those impacts, right? With the students that are here. And we want to make their educational experience the best. And I think we're working really hard. I can speak for John Jay to ensure that is the case.
Yeah, I would say, the college and CUNY, mobilized quite quickly to provide those resources to help support the education mission. And of course, is it fast enough? No. Is it enough? It's never enough. This kind of leads us to, I think, maybe a follow-up, which is looking forward through the remainder of this pandemic, and also kind of documenting lessons learned to kind of materially address those issues that you pointed out today in terms of how do we close that gap between the quote unquote emergency management and the public health community and the communities themselves, so that these kinds of questions are addressed at the beginning and not 1 or 2 years into the event. And so, Jessica, I'll let you finish up, and then I just want to acknowledge the Office for Advancement of Research and the Racial Justice Dialogue series. And so we've been very pleased for their leadership in organizing this, and it's been a pleasure. And I'll turn it over to you, Jessica, to wrap it up.
Yeah, thanks. I was going to thank OIR also. I think this is their last one this year, but they're planning to do it again next year. So look forward to the next series and the next season. We also hope that people have been able to use these series to do more research and pedagogy on these issues. I want to thank our panelists. We already had Dean ElMohandes. We've got Professor Contreras and Professor Rory. Fabulous job. I was supposed to do some kind of inspirational wrapping up, but I don't even know what to say following you guys. But I'll repeat what you all have been saying, which is how very important it is to make sure the voices and the challenges of the most impacted get heard, and that we build systems around making sure that they're heard and that they can do what they do best. Thank you all. Thanks for coming. Thanks for the great comments and questions. Thanks for your participation, and have a great rest of the week.
Are you a fierce advocate for justice? Watch more videos like this and so much more. Subscribe to John Jay's YouTube channel now.